Salam sejahtera, ladies and gentlemen. Good afternoon and welcome, a warm welcome to all of you, as well as to our speaker, Encik Anuar. Our webinar today is a continuation of a series of webinars focusing on Malaysia's competitiveness performance and ranking as assessed and reported yearly by international rating agencies such as the International Institute for Management Development, or IMD, in their World Competitiveness Yearbook, and the World Economic Forum, or also known as WEF, in their Global Competitiveness Report. In the recent World Competitiveness Yearbook 2020, also known as WCY 2020, Malaysia's competitiveness ranking has slipped to 27th position from 22nd position in 2019. Out of a total of 63 countries assessed by IMD in the WCY. This overall competitiveness score and rank is calculated based on 255 criteria. So that's a lot of criteria there, 255 in total, comprising 163 criteria based on hard statistics or data, and 92 criteria are using survey data. Which is obtained from this survey called Executive Opinion Survey. And this survey, the respondents are from the middle management as well as the senior management of private sector. And these 255 criteria are categorized into the 4 competitiveness factors called economic performance, government efficiency, business efficiency, and infrastructure. In our talk today, Encik Anuar will be speaking on Universal Healthcare Coverage Index, a very interesting topic. And I'm sure Encik Anuar will help us to understand by elaborating later on during his talk. What is this index? What is this Universal Healthcare Coverage Index? And what are the components that make up this index? And how is Malaysia performing in terms of the components of this Universal Healthcare Coverage Index. And this particular index is part of the infrastructure factor in the WCY 2020. And before I hand over the session to our speaker, let me first introduce Encik Anuar. Encik Muhammad Anuar bin Abdul Karim has more than 20 years of training and development experience in the area of productivity and quality improvement. He graduated from University Kebangsaan Malaysia with a bachelor's and also a master's degree in statistics. Anuar, as he is fondly called, specializes in productivity and quality improvement programs, such as the Innovative and Creative Circles, or ICC, Lean Management, 7 basic QC tools, 7 new QC tools for problem solving, ISO 9001, a 5S team building, Kaizen training, and also productivity measurement and analysis. Encik Anuar served more than 15 years with the Malaysia Productivity Corporation, that is the MPC, which gave him the opportunity to conduct programs of many companies and government organizations as well, such as Perodua, Fujitsu, Petronas, Jarigali, Sharp Roxy, Nestle Manufacturing, Belda Plantation, UKM, DBKL, just to name a few out of the many that Encik Anuar has done. Encik Anuar is an experienced ICC judge also for the MPC's mini, regional, and also international convention, as well as for internal ICC conventions organized by individual companies, numerous individual companies. He was also a lead assessor and also at times the assessor for the Productivity Award organized by NPC, the Quality Management Excellence Award organized by MITI, and the Selangor Industry Award organized by SSIC. So without further ado, I now hand over the session to our speaker. Over to you, Encik Anuar.
Okay, thank you, Mr. Wong, for a welcome and a detailed introduction of my background. Once again, we meet again in my second session of webinar this afternoon. Okay, once again, I would like to thank MPC for providing this platform for me to share the findings of the competitiveness study on WCY 2020. Okay, the topic that I would like to share with the audience in this webinar session this afternoon is improving Malaysian IMD WCY 2020 competitiveness ranking for the Universal Healthcare Coverage Index indicators. Okay, actually the agenda, basically the agenda of my presentation here will cover 4 sections. Okay, section number 1 is objective and background of the study. Number 2 is key regulators and agencies that involved in these indicators. Number 3, drivers that contributing the ranking of Universal Healthcare Coverage Index. And finally, the recommendation for this study. Okay, for the information of the audience, the methodology of this study is totally based on the DES research study. The write-up and data shown in the slide are extracted from various reports, journal and article locally as well as externally. Okay, let me start our presentation. Okay, the objective of the study to highlight Malaysian current ranking for Universal Healthcare Coverage Index in WCY 2020. That the report that been produced by the IMD. And again, the second objective is to analyze the reason or driver that have determined the current position. And the third objective is to recommend initiative that can help Malaysia to improve on its current ranking on these indicators and consequently its overall competitiveness ranking. So this is the 3 objectives for this study. Okay, the background of the study. The goal of universal health coverage is to ensure that everyone can use the health services they need without risk of financial ruin or improvisation. As is descendant of the Health for All movement, universal health coverage take a broad view of the services that are needed for good health and well-being. In Malaysia, the country healthcare system has been gradually improved upon. A modern healthcare system has wide geographical coverage and provides comprehensive care at minimal fees to the country's citizens. Malaysia is a middle-income country with a long-established healthcare system, providing universal access to the comprehensive package of healthcare services financed mainly through general taxation and private expenditure. The IMD ranked the country competitiveness against 255 criteria, one of which is the Universal Healthcare Coverage Index. This indicator is under the competitiveness factor 4, infrastructure, sub-factor health and environment, criteria number 4.4.5 in IMD WCY 2020. Okay, let's see what is the definition of the Universal Healthcare Coverage Index. Okay, Universal Healthcare Coverage Index is defined as ensuring that all people have access to need health services, which include prevention, promoting, treatment, rehabilitation, and palliation, of sufficient quality to be effective, while also ensuring that the use of this service does not expose the user the financial hardship. That means this cover under the this one SGD 3.81 and also SGD 3.82. This one Sustainable Development Goal. That one the target that been highlighted by the WHO. The target should be improved in 2030. So that's mean for the Universal Healthcare Coverage Index, they cover both 2 indicators in SGD.
Anuar, sorry to interrupt. Because the slide is not changing, can you check and see because we are still looking at the first slide, the cover slide.
Oh, yes, sir.
Yeah, the slide did not change. Can you try change it and see?
Now I changed this one. Cannot?
Oh, we are not seeing the change in slides. We are still on the cover slide.
Okay, hold on.
Now is the second slide, objectives. Yeah, we are looking at objectives. Can you
Now?
carry on? Background, yes. Now we are looking at the
Okay.
background slide. Yeah, I think it's okay now. Please carry on.
Okay, all right, okay.
Now it's slide 4. Okay, please carry on.
Slide 4. Okay, this one, the Universal Healthcare Coverage Index, because this one is under the Sustainable Development Goal, that means produced by the WHO, is under code 3.8.1 and 3.8.2. This one is more related to the Universal Healthcare Index, 3.8.1, and 3.8.2 is for the financial hardship. Okay, there is two indicators, important indicators here in the SGD 3.8. So SGD 3.8 covers two indicators, 0.1 and 0.2. Okay, the goal of Universal Healthcare Coverage Index is to ensure that all people obtain the healthcare services they need, prevention, promotion, treatment, rehabilitation, and palliation, without risk of financial ruin or impoverishment, now and in the future. Okay, the indicators or the indicator is an index reported on a unitless scale of 0 to 100. So this is the index, 0 to 100, which is computed as a geometric mean of 14 traces indicators. So this is the sub indicators under the SGD 3.81, under the SGD 3.81. So we have another 14 trace indicator of health services coverage. Okay, so in terms of the drivers, whether our ranking is low or high is based on these 14 trace indicators. So this definition is from the source of definition is from the World Bank, World Development Indicator 2013. Okay, next slide is the historical and current performance. Okay, for the SGD 3.81, this one the healthcare coverage index for 3.81. Okay, we can see from the chart here, the world chart here, is based on the global monitoring reports produced by the WHO in 2019. Okay, see here the color is yellow here. Dark orange, for Malaysia here is dark orange. Okay, so the score or the index of Malaysia here is around 70 to 79. This one is reported by the WHO. Okay, Universal Healthcare Coverage Index Malaysia is at level 73. Yeah. Okay. Although the report is 2019, the current data reported by the WHO is 2017. Okay, compared to the 70 in 2016, that means is increase of 3 points. That means compared to 2016, our index is much better of a 3 point compared to the 2016. Okay, yeah. Okay, this one is for SGD 3.81. 3.81. Okay, let's see what is the SGD for 3.8.2. Okay, 3.8.2. Availability of sustainable development goal of financial protection in the global database. You see here, the color is light blue. Color is light blue, that means considered is not applicable I'm not sure whether we provide the data or not to the WHO. Based on the global monitoring report released by WHO in 2019, data on SGD 3.8.2 on financial protection for Malaysia is stated as not applicable. It's not data not available, but it's not applicable. Okay, I made a reference from the WHO website in terms of this definition, what is not applicable. There is no absolute definition on the not applicable, but for the data not available, yes, they have, because this is very difficult. There is no population here, and so there's one, the data is not available. But in our case, it's not applicable. Maybe we cannot produce, or that is my assumption that the data or the color is a mistake in terms of color, or the data is not available. The WHO is not able have data. Maybe it's not submitted the data to the WHO by a Malaysian. Okay, so that is the case for the S 3.8.2. So, okay, in terms of current competitiveness ranking reported by MDWCY 2020, okay, this is the two comparison data, 2019 and 2020. Okay, the orange color is the value level, and the blue color is rank. So that means if you compare the color of the value level 2019 2020, that means it is an increase of 3 point in terms of index. Okay, in terms of index, increase of 3 point. But in terms of rank, in 2019, our rank is much better than in 2020. 44, rank in 44, while in 2020, our rank is number 49. Okay, it's down almost 5 point in terms of ranking. Okay. Okay, according to the report, Canada obtained the highest index with 89 point. This is ranking number 1 in terms of WSC index. Canada is score 89 point. Compared to Malaysia, is the 73 point. It's ranking number 1, and Malaysia score 73, ranking number 49. So it's huge rank. Although the score is not very far from each other's, 73 and 89 point. But in terms of ranking, it's very huge. Number 1, and Malaysia is number 49. Okay, this is the graph compiled by the WCY or IMD, WCY. This is the ranking of Malaysia, number 49, value 73 point or index value, and Canada value is 89 point. So that means there's a huge one, although the score or point is not very big, different from Malaysia and Canada. So that means in order to increase our position in the ranking, we have to increase our point here up maybe around 80 point, maybe around 80 point. Okay, maybe around 80 point. So that means we can increase our ranking from 44 to the maybe top 20, maybe top 20 in the 63 countries. So just increase of 7 point, just increase of 7 point, we can increase our position from 49 to the top 20. Okay, that is the we want to make sure that our ranking is improved after this. Okay, the main challenges in analyzing this indicator to determine the exact definition used by AMD to produce WHC file, which require more information in terms of definition used by the IMD, because the definition and the data all been produced by the WHO or OECD or ECD data. So that's mean the exact definition used by the AMD, there is not, we cannot. I cannot dig any reference in the web. All reference is based on the WHO data, OECD data, and World Bank data. Okay. Right. There is challenges on type 4 and also type 2. Right. In terms of data, it's also very hard to identify whether they use data 2016 or 2017 or 2019 or 2018. But my assumption is that the data used by MD is of 2017 data that produced. That is the latest data that I can find in the web. So hopefully it's true. Okay, the key authorities and regulators for WHE. Main key authorities is MOH. The department involved here is Malaysian National Health Account Section, Institute of Health System Research and Institute of Health Policy, and Institute of Health Metrics and Evaluation. So under the MOH, there's three agencies that involved in producing this information or data under MOF. Okay, the data related here is the healthcare expenditure, and then for sustainable development goal, universal healthcare coverage index by public and private financing, Malaysian health system mortality rate and diagnosis. This one, but this one is for SGD they cover this one, but for the USC it's not cover mortality rate. For SGD, yes, of course, they cover the mortality rate. Okay, the USC is just cover undiagnostic NCD disease. And then procurement, purchasing of medicine, healthcare facilities, childhood immunization, financial risk, distribution of OPP payment, healthcare utilization, epidemiology translation. So that is the information or report that they produce relating to the WHC, SGD requirement here. Okay, ada lagi self-reported chronic illness, changes in disability of coverage of antiviral therapy, actively practice doctors. So this one is covered under the SGD 3.8.1. Medical specialist also covered. Annual per capita outpatient utilization rate. So this one is cover under the 3.8.2 for the financial risk. Okay, agencies number 2 is Ministry of Women, Family and Community Development. This one they produce data on family planning, demand family planning. This is one of the indicators under the SGD 3.8.1. So this means this information is very useful in the for the indicators of 3.8.1. And then we have a Department of Statistics, data on aging and population projection. This one under SDG, but in the 3.8.1 is not covered here. Health status of Malaysia. Okay, this one also is not covered. Is covered under SGD only. And then expenditure share and private and public acute care hospital. Okay, and last one is the Government of Malaysia Fee Amendment of Fees Act 1951, and private healthcare facilities and services, private hospital, and Private Healthcare Facilities Regulation 2006. So that is the key authorities and regulators relating to the WHC. Okay, so I think we should have a short break for entertain any question from the audience. Okay, back to you, Mr. Wong.
Okay, thank you, Anuar. Okay, we open to participants for questions at this point. If there are any questions related to what has been presented and explained so far by Anuar, please post your question in the chat box so that I can relay it to Anuar for him to answer. If there are any questions from participants, please. While waiting, I will just ask one question here, just for clarification, Anuar. You showed just now that our score, our UHC, Universal Healthcare Coverage Index score, has increased, right? From the previous report to the 2020 WCY report, is increased from 70 to 73, if I remember correctly. But at the same time, our rank has dropped. Yeah? Our score increased, but our rank dropped. Is there an explanation that you can let us know? Why is that so, Anuar?
Yeah, from I think one of the okay, we check again at the data here. Okay, here from here. Okay, the score in 2020 is 73, and then compared to the previous year is 70. Maybe in terms of the ranking and the value from other country, maybe is for 2020 is much higher than Malaysia. That's why the ranking is their ranking is much better than Malaysia. Although our ranking is our index is higher than previous year, but other country the index is much higher than Malaysia. Okay, that's why we can see that although our index is compared to the previous year is high, but in terms of ranking, I think it's low. So I think that is the reason why our ranking is still at the bottom.
Okay, that means you are saying other countries have improved on their score at a faster rate or by a bigger amount, a bigger number.
Yes,
compared to Malaysia. Malaysia only improved by 3 points, from 70 to 73. Other countries maybe already more than that, and then they overtake Malaysia. Okay.
Because we can see here in terms of point also, it's not very far. Malaysia is 73. I think, for example, number 30, for example, ranking number 30, 77. That means it's just 4 points. The ranking is around 19. The difference is around 19. That's why we just improve our index. Yeah.
Okay, I see. Will you be showing us how this calculation is done, the score, Anuar, later on how they determine the score? You know?
Yeah. But this one under the drivers.
All right. Okay then. If that's the case, we carry on then. No other questions from participants so far. Let's carry on. Over back to you, Anuar. Please carry on.
Okay. Thank you, Mr. Wong. So next section, I would like to share with the audience the drivers contributing to the current ranking of USC. So we already see that there is in terms of USC Service Coverage Index, our ranking, our score is 73 in 2020. So the contribution of the score in terms of index is based from the 4 components here. Okay, this is 4 components of USC Service Coverage Index. Okay, component number 1 is reproductive, maternal, newborn, and child health. So this is component number 1. Component number 2, infection diseases. Component number 3, non-communicable diseases. And component number 4 is service capacity and access. And so this is the four components that contribute to the higher or lower ranking in our USC index. Okay, let's see component number one. What is the indicators inside the component number one? Okay, indicators number one is the family planning, antenatal care. That's when the mom have to visit 4 times. Child immunization, DP3. Care-seeking behavior for child pneumonia. So this is the four indicators comprises in the component number one. Okay, component number two, infection diseases. There is a tuberculosis treatment, HIV antiviral treatment, malaria prevention, and at least a basic sanitation in that country. So that means it is also four indicators covers under the infection diseases. Okay, component number three, non-communicable diseases, which cover normal blood pressure, mean fasting plasma glucose. This one is for the diabetes, and tobacco non-smoking. So this is three indicators in the non-communicable diseases. And the last one, component number four, service capacity and access, cover the indicators of hospital beds density, health worker density, and international health regulation index. So this is the indicators that Malaysia have to produce and forward the information or the data to the WHO to come up with a ranking on the SGD 3.8.1, 3.8.1 for USC Service Coverage Index. Okay, so let's see one by one of each four component of USC Service Coverage Index. This one is also in terms of their index scoring. That means 0 to 100. 0 to 100. Okay, because the definition of the index of USC is 0 to 100. If our score is high, that means is much better than score is low. Right? Score is low. Okay, so we go one by one of each indicator. Okay, this is the indicator for overall. For overall, UHC Service Coverage Index. This one under the SGD 3.8.1. So in terms of the score, Malaysia is 73 point. Yeah, Malaysia is 73 point. Okay, compared to the ranking number one is Canada is 89 point. Okay, and then nearby country Singapore 86 point, Korea 86 point, and lower than us is India 55, Bangladesh 48, and Indonesia 57, and also Philippines 61. So in terms of ranking, score is in terms of the index numbers here 73 is quite high. It's quite high compared to the rest of the Asian Southeast Asia country, except Singapore 86. So, but in terms of the ranking, we are still at the bottom, 40 something. Okay, that's mean we just increase maybe 5 point or 7 point, 7 point here. That's mean we can match with the Thailand score here. Okay, so that is the I think we have to study the thing how to increase the index here. This one is the overall. From the overall, we have to identify which component is good and which component is our country is lack. And so that's means we have to study the component first, then we tackle which component is very low score in terms of index. Okay, we go for the four component. Four component. Drill down the data. It is component number 1, reproductive, maternal, newborn, and child health. Okay, in terms of index also is very high, 76. Okay, 76 point, and compared to Singapore is 90, Korea is 89, and Canada number 1 is 94. So that's mean it's still below, although it's 76, is compared to other countries is above 90%, and 90 score. So that's mean this one also we have to study why which indicators in this component number 1 is contributing to the lower score in our component number 1. So after this we have to study one by one for each indicator. Okay, component number 2, infection diseases. Okay, Malaysia score is 68. Okay, compared to the rest of the country, is still below Malaysia, except Singapore and Thailand. And Singapore and Thailand is higher than Malaysia score. Okay, and Canada is ranking number 1 is 82, 82 score. Okay, this one also one of the indicator that we have to study. Which indicator that we can improve further to make sure that our index score for infectious diseases will be increased. Maybe around 72 or 74, like what recorded by the Thailand. Okay, for non-communicable diseases, Malaysia's score is 62. Still down compared to the other countries. Also Thailand also is higher than Malaysia, 69. And then Indonesia lower than us, 58. And France also is very low into non-communicable disease. And Bangladesh is still lower than Malaysia. And Canada is number 81, and Singapore is number 78. So this one also one of the component that we have to study, which indicator that contributing to the lower score in our non-communicable diseases. Okay, the last one is the service capacity and access. Okay, from here we can see that our score is quite high, 89, 89 point here, compared to the other countries. Okay, India, Indonesia, okay, and Thailand also. We exit Thailand, we 89, Thailand 88. So that's mean it's already good in terms of service capacity and access. So it's not, I think it's not one of the contributing factors that contribute to the lower ranking of Malaysia USC index. So this is not one of the factors. The 3 factors, component 1, component 2, and component 3, maybe we have to study which indicator that we have to improve. Compared to this component number 4, I think is already okay. Okay, we drill down for each component. The component number 1, the family planning. Yeah, the family planning here. So in terms of index, Malaysia's score is 53. 53 is same figures of Philippines, 53. Okay. Compared to Thailand is 91. 91, the score is very high. Okay, in terms of family planning. And then the rest of, for example, this one, Canada 89 and China also 95. Is score is high in terms of family planning. This definition of family planning is a percentage of women of reproductive age, that's been 15 to 49 years old, who are married or in union who have their needs for family planning satisfied with modern method. Okay, they're doing the modern method for the family planning. This means if our method is all in terms of modern method we use for family planning, the score is high compared to the we use all various type of method. So this means uh, the the index is low. So this is data that I can show you. Okay, this is data. Okay, we take China here. Okay, any modern method for family planning, that's why the score is very high. There is no any method. Okay, in this particular indicator, we want to make sure that uh, the country, in terms of family planning, they use any modern method. So in terms of Malaysia, you see here, modern method, I think around 60%, and 40% is any method. A traditional method, for example, so that's mean our ranking is low compared to the countries that use any modern methods in their family planning. Okay. Okay, for antenatal care, for visit, 4 times visit, Malaysia also score slightly low, 74 point, compared to the rest. Thailand 91, Singapore 98, and the rest. So that means we have to improve this one in terms of antenatal care, 4 time visit by the woman or mummy. Okay, pregnancy and delivery care percentage of women aged 15 to 49 years with a large birth in a given time period who receive antenatal care 4 times or more. Okay, so that means Malaysia point is a little bit higher in terms of antenatal care. Okay, so this means we have to study whether this actually happened or not. Okay, so I have to get more information on this one. Okay, this is the data that one produced by WHO, GHO. So in Malaysia here, okay, in terms of data, there is at least blue color is at least 1 visit, and grey color at least 4 visit. In terms of Malaysia, there is no grey color here. There is no grey color here. They have only the blue color. So that means I also don't know how they produce the data. And this one also sourced from the WHO, WHO international comparison data compared to the OECD here, data OECD. Okay, 4 time visit is higher, near to 100%. For Malaysia, I'm not sure what is the percentage here. What is the percentage here for at least 4 time visit. So there is no figure here. Okay, number 3 is child immunization, BP3. That means the 3 times the child have to have their immunization. Okay, child immunization is percentage of infant receive 3 doses of tetanus, protozoa, and contained vaccine. So this one is quite high. Malaysia is quite. That means for Malaysian child, most of them has this child immunization start from their birth, and these 3 immunization, I think there is no problem in Malaysia. It's because the score is quite high here. Okay, I would say from the child immunization, this one produced by UNICEF. Okay, we see here Malaysia color is around here. Okay, this is the color for Malaysia. Okay, dark green, dark green. So this means it's around 95 to 100% of child immunization for 2019. So this is not one of the indicators that contribute to the Malaysian ranking. Okay, the last one, care seeking behavior of child pneumonia is also quite high. The percentage of children under 5 years age with suspected pneumonia, cord and different breathing, not due to the problem in chest blockage, nose. In a to be preceding that critical health facility provided. So that's mean in terms of the index is also quite high. So I think it's not one of the contributing factors that lowered the index of Malaysia. Okay, we see the component number 2, infectious diseases. Okay, tuberculosis treatment. So this means it's around high also. Percentage of incident tuberculosis cases that are detected and successfully treated. That means it's quite high. Okay, compared to the rest of the country, is Malaysia maybe it's quite high compared to the Thailand, compared to the Philippines, compared to Japan also we also go quite high. Indonesia, so this means it's not one of the indicators that we have to study to improve. This means we can maintain these indicators or what we're doing now. Okay, in terms of community treatment, and it's Malaysia. So Malaysia percentage is higher than the OECD in terms of tuberculosis treatment. Yeah. Here this is OECD, and Malaysia is above them. Malaysia is above. Okay, HIV, antiviral treatment. This one is lower. I think this is one of the indicators that we have to study. Why our index is very low? It's not very low. Other countries is lower than us. Like for example, Indonesia and India, Philippines, and Sri Lanka. But if we can increase this one up to maybe for 70 point, that's maybe increase of total USC index. So this is one indicator that we have to study a lot. That means from this improvement, we can see that there is the improvement of total or overall USC index. Okay, so this is much one of the indicators point, one of the point indicator that we have to study in order to improve the rating here or the index here, up maybe to 70%, or near to 70, near to 70. Higher than Singapore. Okay, this one is compared to this one. We see that Malaysia is around bottom, around bottom in terms of antiviral treatment. Why? We have to study lah. 45. Okay, data is for the UNAIDS. Okay, at least basic sanitation. So we score high. So this is not one of the indicators contributing to lower score. What is the definition here? Percentage of household using the at least basic sanitation facility. That's when Malaysia is good in terms of waters and sanitation for all population in Malaysia. So that's mean in terms of this indicator, I think is higher. It's higher, and we can maintain this basic indicator sanitation. Okay, assets to improve sanitation. Okay, so Malaysia here is around 96 compared to the Malaysia around 96 and compared to the 98 for OECD. Okay, it's quite high. The among the top countries in terms of improved sanitation. So data is 2015 and produced by WHO. Okay, and normal blood pressure. Normal blood pressure is also one of the indicators that we have a quite high index here, 81 point. And the rest of the country also have a very high point here. Okay, except India and Bangladesh. So this means this one, if you can if you want to increase, maybe it's up to 90 point. Okay, or if you want to maintain this one, is I think it's okay. But right now we can maintain this one 81 point score. I think it's quite okay. But if you want to improve, is up to we can up to 90 point. 90 point. Okay, this one is mean fasting plasma glucose for diabetes. Diabetes is standardized mean fasting plasma glucose for adult age 18 years and older. So this one is one of the indicators that we have to study. Okay, why our score is very low here, 54. The rest of the country also score is very low in terms of mean fasting plasma glucose. So 54, that's mean we can increase to 60, for example, 65, for example, as reported in Singapore here and Canada here. That's mean around 60 point. That's mean we can increase our total USC index. So this is one of the indicators that we should study. Okay, this diabetes prevalence among adults in Malaysia. Okay, the blue one is data for 2014. This is the male, this is the female. So this means Malaysia is around here. It's quite high. It's quite high in terms of prevalence. Diabetes prevalence is quite high in terms of the population diabetes compared to the rest of the world. Malaysia is quite high. Okay. So we have to make sure that this one is will be reduced. Maybe it's around here, for example. Okay. Okay. The other component is the tobacco non-smoking. The score also is very low. 56. What the definition here? It's standardized prevalence of adult. That means it's more than 50 years old, not smoking tobacco in the past 30 days. Okay, so the score is very low compared to the India, 76, and Canada 73. Okay, so Malaysia is around 56. Okay, but I think how they collect the data, I'm not sure. How they collect the data, the MDAP more than 15 years old, not smoking tobacco for the past 30 days. Maybe they use a survey. Maybe they use a survey. From this survey, they can come up with a percentage and then identify what is the actual figures for the index. Okay. Okay, standard prevalent estimate for daily tobacco smoking among person age 15 and above. So this is Malaysia. Okay, it's quite high compared to the OECD and Asia Pacific countries. So this mean that Malaysian population is smoking higher than other country here, like Philippines. Okay. Okay, this one is for the component 4. Service capacity and access. Hospital bed density, Malaysia score high. Okay, 100%. Okay, all right. What is the definition here? Hospital bed per capita relative to the maximum threshold of 18 per 10,000 population. In terms of this definition, 18 per 10,000 population, Malaysia is, in terms of score, index is high, almost perfect, 100% and 100 index score. Okay, so this means it's not one of the indicators that contributing to the low ranking of our nation. So in terms of the actual data that produced by the OECD, data on healthcare 2018, okay, this definition is different from the WHO, WHO and global SDG definition, but this one is OECD. The definition hospital bed per 1,000 population. So for these indicators, Malaysia rank is a little bit lower, 1.3 compared to the Korean DPR, Japan. So it's higher than us. Okay. So this definition is much better to us. The 18 per 10,000 population compared to the hospital bed per 1,000 population. So it's lower than other country in OECD. Okay, health worker density. Okay, our ranking, our index number as 72. Okay, this one is definition: health professional, physician, psychiatrist, and surgeon per capita relative to maximum threshold for each country. So that means it's quite high, 72. Compared to Thailand, 70, and the rest of the country, Philippines also very low, Sri Lanka is very low, Indonesia, and if you want to improve this one, maybe we can increase up to 80%, 80 point here in terms of the health worker density. Okay, we take example for the doctors and nurses here. Okay, doctors and nurses here, data from OECD 2018. You can see here in 2015 data, Malaysia in terms of the score here, 2015 here is 1.5. 1.5 compared to Australia is 3.6. OECD country here 3.4. So that means it's quite lower than the OECD country here. Okay, in terms of ASEAN Pacific, is our score is higher than the ASEAN Pacific country. This one. So, but in terms of OECD countries is quite low, compared to this, the availability of the doctors of per 1,000 population. Okay, in terms of nurses also, our score is quite high, 4.1, compared to the OECD countries, 9.0, and ASEAN Pacific, 8.0. Okay, but the rest of the country is lower than us. Lower than us. Sri Lanka, Indonesia is in terms of the nurses and doctors. Malaysia is record rate is quite high numbers for 2015. Okay, International Health Regulation Index. So our score is quite high. Okay, what is the definition here? International Health Regulation Core Capacity Index, which is average percentage of attributed of 13 core capacity that have been attained. So this is the index that whether Malaysia can assist the international health in terms of the regulation. And so that's mean the score is quite high. Malaysia, I think, is quite assist them in terms of the core of capacity index. So this means quite high, 97. So it's not one of the indicators that we have to improve. Or we just maintain this one, or we just proceed with what we are doing right now. Okay, for the 3.8.2, 3.2, but for the USC service index, the 73 point here is not covered for 3.8.2. It's covered only 3.8.1 at 70 score, 70 score. But this one is just to share with the audience of Malaysian 3.8.2 for financial risk. Okay, we can see here out of pocket here. Okay, OPP share of total expenditure. Okay, here is quite high. It's quite high compared to the recommended by the WHO is around below 20. Below 20. So this means our OPP is quite high. Okay, in terms of financial risk is quite high also among nations. Okay, OPP share private sector also is quite high, 77%. So this means is in terms of private sector expenditure, OPP contribute 77% of total private healthcare expenditure. Is totally is very high, totally very high percent here. Okay, in terms of expenditure of the GDP, OPP, okay, 1.59 compared to the GDP. So this means it's not high enough. It's 1.6 only. But in terms of total healthcare, it's quite high. But in terms of overall GDP, is just 1.59. Okay, OPP as health expenditure of public and private providers. Okay, money goes to. Okay, the money goes to private providers. Here, the red color here, and public providers. So that means the population or the rakyat have to pay most of the services for health to the public providers here. Is around 95%. Okay, it's around 95%. It is their own money, not from the insurance or whatever, but it is from their own pocket money. Okay, so for 3.8.2, if we want to reduce the risk of financing, that means we have to reduce this figure, the red color. Okay, in terms of out-of-pocket expenditure as a share of total health expenditure, this one is the data from the World Bank, but it's old data, 2013. From here, we can see that Malaysia is higher than the rest of the country, upper middle income, OECD, USA, Norway. So this means, in terms of percent of OPP, Malaysia is higher than other countries. Okay, for example, this one we take USA here, it's very low in terms of OPP here. Although the GDP is very high, GDP is around here, but in terms of OPP is very low. Okay, that's why their ranking is very high. Otherwise, Malaysia is GDP is 4, but the OPP is 40%. So it's quite high. This means this is the problem of Malaysian for the get services for the healthcare. So this means we have to reduce this one in terms of the OPP of total healthcare expenditure. Is like, for example, in OECD country here, just OECD country here is high GDP, but in terms of OPP is very low. So it is our target. Okay, is for the out-of-pocket expenditure share GDP. So Malaysia also is around here. Okay, less GDP, but OPP is of GDP is 1.5% just now. So this means it's quite low. GDP is low and OPP is low. Compared to the this one, you take OECD country. OECD GDP is high, but the OPP is around Malaysian. So this means OPP percent of GDP is around Malaysia figures, but in terms of GDP is higher than Malaysia. Malaysia is around 4%. OECD country is 4.6%, for example. So this means we have to also to reduce this one. Okay, reduce this one, increase this one. Increase. Okay, so that is the section 3, drivers contributing to the current ranking for universal healthcare coverage index. Is for the 3.8.1. Okay, the further recommendation before I complete my presentation. So is certain recommendation here. Okay, number 1, to improve the sustainable development goal (SDG). The SDG 3.8.1 universal coverage, universal healthcare coverage service index from 73. This is my recommendation from the analysis that have been done, to 80, which will improve Malaysian ranking to top 20 countries. So we just improve 7 points, just 7 points, we can improve to ranking number top 20. So this is one recommendation from the study that I have done. Okay, number 2, improve the index on reproductive, maternal, newborn and child health, especially on the indicators such as family planning, score number 53 is very low, and antenatal care for visit 74. But which one we have to consider? Consider this one first, the family planning. That's been for next year. We have to study why our index score for family planning is lower. Then we go for the next one, for the antenatal care. Okay, number 3, improve the index on infection diseases component, especially on indicators such as HIV treatment, because our index is 46, and tuberculosis treatment 70. But we go this one first, antiviral, HIV antiviral. Why our score is low? Okay, so we have to study this one in the future, and then from there we can identify and improve, and then our ranking will be improved. And the third one, improve the index on non-communicable diseases, especially on the indicators such as mean fasting plasma glucose for diabetes. Okay, this one, our index is 54, and also tobacco non-smoking, 56. So that's mean these two indicators should be studied by the our MOH, Ministry of Health. Why these two indicators for WHO USC index, the index score is very low. So maybe if they analyze the data for previous years, maybe they can improve. Next year, our score will be high for USC SGD 3.8.1. So this one is from the analysis done. And then the other recommendation is based on the study that have been done for the best practices of the countries that having a high ranking compared to our. For example, like Canada. Then this is the initiative that's done by the Canada. Okay, number 1, what is their initiative done by the higher ranking from us? Number 1, increase investment in affordable quality primary health care, which more efficient and equitable, producing higher value and better healthcare outcome. So this is the one of the increase investment. So this is the idea in affordable quality primary health care. So this is number 1 recommendation. Redouble effort to engage the private sector and unlock new model of health financing and delivery. The unmet coverage of financing need to be too vast for the public sector to close the gap with the private sector. So this means make sure that the services in the public sector we have to close the gap with the services given by the private sector. So this is the we have to study what the initiative done by the country that have higher ranking than us. Okay, number 3, align ways of working with global partners to build stronger health system for USC and to reduce inefficiency and support country effort to deliver on their international commitment on health. So this is another initiative done, working with the global partners to build a stronger health system for USC. Okay, number 4, evaluate USC progress regularly, which include the quality of primary care, health coverage, expansion initiative, inequality of health outcome, and financial hardship. So this is monitoring. Should monitor the data on USC by the relevant parties. So that means we make sure that we have a data, and then we can easily do any improvement from the data. Okay, number 5, assess the healthcare based on need rather than ability to pay. Okay, this is initiative implemented by Canada. It's called True Medicare. True Medicare. Okay, it's like an insurance, private insurance, government insurance. It provides relatively equitably access to physician and hospital service through 13 provincial and territory tax-funded public insurance plan. Public, that means government public insurance plan. Canadian Medicare is more than a set of public insurance plan that more than 90% Canadian view is an important source of collective pride, and this means they very agreed in terms Canadian very they are very satisfied with this Canadian Medicare. Despite point to the implicit social contract between government, healthcare providers, and the public. So this is one initiative that we can implement in Malaysia to reduce the financial risk of the population. Okay, number 6 is strengthening national healthcare data system, database, such as promotion, preventive, corrective, rehabilitative, healthcare, which really support USC. This data is very important. This means, for example, USC indicated there is 14 indicators there, so the data should be we should have every year. This means strengthen in terms of data system here. For example, at the beginning of my presentation, in the WHO report, the Global Monitoring Database 2019, there is no data on Malaysia for the 3.8.2. So this is one of the problem for us. Maybe why? Because that one is reported already in the WHO Global Monitoring. Okay, so that's conclusion here. Okay, Malaysia has achieved universal health coverage appear to be supported by the finding from brief assessment of the country health system. Financing of healthcare as a progressive distribution of every household out-of-pocket payment are relatively small, especially for the poorer household. Okay, overall, the population enjoy high level of financial risk protection, and the use of public healthcare services is equitable distribution. Okay, in terms of the poorer in Malaysia, I think there's in terms of out-of-pocket payment is relatively small. Maybe this one is a problem happen in the middle M40 people. Okay, in Malaysia, the fact that the poor are spared a high burden of out-of-pocket payment can be partially attributed to extensive network of public healthcare facilities. Okay, this provided a wide range of very cheap health care service to those is needed. Okay, in public hospital or clinic, the poorer have to pay only 1 ringgit. 1 ringgit. So this means quite cheap. Okay, direct household out-of-pocket health payment in Malaysia are in fact almost exclusively for the purchase of private care. Out-of-pocket payment distribution favor rich household indicate that the general public care is mainly purchased and consumed by a rich. Okay, this one private usually by the rich people and finding which should not be surprised since this household is more likely to be able to afford such care. Okay, the last point here, increasing public demand for better quality care as well as changing demographic of diseases burden are putting the Malaysian public health system under tremendous strain. Major health reform are being discussed with government, although very few details have been released to the public. It is likely that the future system would involve social health insurance, a single purchaser, and both public and private provision. So this is the last point here, social health insurance for each person in Malaysia. That is the target we can have to reduce the financial risk of the population. Okay, so I think that is all for my presentation. Okay, back to you, Mr. Wong.
Yeah, okay. Yep, thank you, Anuar. That's a lot of data and charts that you have shown us. Yeah, interesting to look at the numbers and also comparing Malaysia with other countries' performance. Let me check whether there are any questions from the participants today. Okay, for those who are attending this webinar, please feel free to post your questions. Okay, questions that you would like to ask Anuar our speaker today to elaborate or to clarify certain things, please feel free. And while waiting for the questions, I will ask one question here. I think I saw quite a number of slides, and Anuar, you shared on out-of-pocket expenses, out-of-pocket payment or expenses related to the healthcare. Just to clarify that this is not being used to measure inside the UHC, right? The Universal Healthcare Coverage Index, not measured under that index. Am I right? For WCY 2020 report.
Yes. This one is measured under the SGD 3.8.2. Our USC is SGD 3.8.1. So this means it's not measured under our.
Okay, so the UHC is actually taking from the SGD, Sustainable Development Goals 3.8.1 only, right? That particular indicator only. Okay,
yeah, right.
Yeah. Also, interestingly, you showed us about the components of the UHC. Yeah. And I can see that some Malaysians are performing very good. Yeah, even 100 marks, maximum mark. Yeah. Like hospital bed. Yeah. Certain indicators. There are 4 components there, and there are certain indicators like hospital bed density. There are 100. Score is 100, which is the maximum. So also I noticed a low score. Yeah, low score. I noted down like family planning related. We are low score. And antenatal care. Antenatal care also quite a low score, I think. Maybe not as low as family planning. And then HIV, antiretroviral treatment, mean fasting, plasma glucose, tobacco non-smoking, and probably also health worker density in terms of physician, psychiatrists, and also surgeons, the numbers in Malaysia. So is there any recommendation, Anuar, from you related to what our ministry, especially our MOH, can do to help to tackle these low score indicators? Any view on this, like antenatal care, or family planning, or HIV antiretroviral treatment? Because these are the low score that I think is pulling down our Malaysia's overall score for UHC index.
Okay, Mr. Wong. Okay, let's say for example we take this one for the low score of the which one? Okay, this one, for example, tobacco non-smoking.
Tobacco non-smoking. Yeah.
Okay, tobacco non-smoking is a 56. Out of 100, we score 56. It's quite low. So this means this one is based on the data here in terms of Malaysian data compared to the rest of the country, OECD country. We can see here is quite high, compared to the rest of the country. Okay, 2004, one blue color is 2014. Okay, here. Okay, it's around 30%, around 15%. Okay, around 30%. Compared to the OECD country is less than 10%. That means how to improve this one? I think the World Bank also has identified various activities how to improve this indicator by promoting that's tax increase the tax, for example. Okay, but in terms of the figures there, here tobacco non-smoking, this figure is based on the adult more than 15 years not smoking tobacco in the past 30 days. That means they should have come up with a survey and then ask the people whether they smoke or not for the last 30 days. So that means this is the figure that the MOH has to done the survey for this one. Okay, so that means they have to ask the smokers here whether they smoke or not for the past 30 days. So this is quite difficult to gather this type of data, because they have to do a survey of the smokers, whether they smoke or not for the last 30 days. So yeah, I think the WHO is having a problem. Maybe this one also, in terms of data compilation, is based on the maybe estimation data lah. So that's mean I'm not sure, because this one.
So for this particular indicator, actually, what you have shown us just now, Malaysia is actually performing better than OECD countries in terms of the score for this one.
For tobacco.
For tobacco non-smoking, right? You showed. Are they performing better?
Oh no, it's not better.
It's worse. Okay.
Okay. Because our smokers is much more than the OECD countries.
Okay, I see.
Because this data is not like the this one, because it's not smoking.
I see.
Is smoking. It's quite different.
Okay. Okay. So yeah. Okay, I see. All right. So maybe Malaysia government, or in this case MOH, should take certain measures or steps to reduce the tobacco usage, or smoking incidents in Malaysia compared to OECD countries, the more developed countries.
Okay. But this one, for these figures, is based on the survey, I think, Mr. Wong, because there is no data, the hard data for this not smoking tobacco for the past 30 days. But for this one, we have a data. Daily tobacco smoking.
Then we look at. Well, okay. Why not we? Okay, maybe one more indicator that I'm interested to look at. Let's say the antenatal care. So, is there any suggestion how Malaysian government, especially MOH, can help in ensuring we have 4 or more times of antenatal visits? Yeah, 4 plus.
Okay, visits. This one, for visit. That's mean for the mom of the baby. That's mean they have to.
Correct. Those during the pregnancy.
4 times. This one is not for pregnancy, after the birth. And then the percentage of women is 15% with a live birth in a given time period, who receive maternal care that means after the birth the baby, that means they have to visit the hospital or clinic 4 times. This is figures maybe Malaysia is lack of, but before birth, that means I think there's no problem. We have the figures, but after the live birth of the baby, usually the mom just stay at home. I'm not sure whether this one the figures is 74. I think it's quite high also in terms of compare this one.
Okay. All right. Thank you, Anuar, for helping me to understand better. I don't have any questions being posted here. I don't see any questions, and I think with that, it's time to end this webinar session.
Okay, thank you, Mr. Wong.
Thank you very much again, Anuar, for the interesting talk here related to this UHC, Universal Healthcare Coverage Index, and also Malaysia's performance in this competitiveness report by IMD called the WCY 2020. So have a good day to everyone who is in this webinar. And also have a good weekend also. Weekend also is coming. So same to you also, Anuar. Thank you.
Okay. See you again, Mr. Wong. Thank you for moderating my session.
All right. See you again in the next webinar.
Okay. Thank you.
Goodbye to everyone. Take care.
Bye. Okay. Thank you.